SARS-CoV-2 pandemic brought on challenges to access to care for all. It additionally heightened access issues for the Medicaid population who was already facing many challenges. Pennsylvania created a teledentistry Medicaid policy to address many of the concerns such as access, protective personal equipment PPE, supply limitations and cost, as well as maintaining the provider network. Realizing that this new policy will potentially lead to reduction of new disease and prevention of the advancement of the existing disease, therefore reducing the need for emergency department visits, Pennsylvania decided to make this a permanent policy. This presentation will cover the topics of the concerns and the solutions of the access to care for dentistry during the SARS-CoV-2 pandemic, as well as Pennsylvania's Medicaid teledentistry policy, including the challenges and the reporting regulations, and we will end with the potential benefits of this policy. During the initial stages of the pandemic, some of the access concerns were due to the office closures and the reduction of their services, in addition to the limitations that they had specific for the dental setting, with the PPE further reducing access to care for the patient. Also, in the initial stages with the stay-home orders, patients' either hesitation or concerns to leave and enter into a medical or dental setting was heightened during that time. The potential of all of these concerns is that there could be a high increase in new dental disease due to the lack of reduction in preventive care, as well as an increase to the emergency department visits. So the solution to the previously mentioned concerns came in the form of teledentistry, which would provide emergency visits as needed, preventive education as well as some treatment, and offer tobacco cessation counseling, especially given that COVID-19 was of initially respiratory concerns. Secondary benefits that could come from teledentistry is that it would help to establish interaction between the patient and provider, which has shown previously that it would increase in-person visit show rates. The following codes were added to the teledentistry policy. D0140, limited oral eval problem focused. The only limitation would be patient initiated. D1310, D1330, nutritional counseling and oral hygiene instructions. These two services must be provided together at the same time and for a minimum of 20 minutes, and only permitted once every 180 days. D1320, which is the tobacco counseling code, had the same limitations as the medical service. D1206, topical application of fluoride varnish once per 3 months. There were specific challenges with a few of these codes. For example, with the nutritional counseling and the oral hygiene instructions, since these were newly reimbursable service codes, there was a concern with the increase of the cost as well as potential abuse or misuse for the in-person visits by the providers, meaning what that would look like if they started to create separate appointments just for these two services. So the way to remove this barrier was to place a limit for the in-person visit that these services must be in conjunction with another service. For the D1206, the fluoride varnish placement, the dentist would have to be the one that determines how to get the prepackaged amount of the fluoride varnish to the patient or their legal guardian. They could either send the staff, for example, especially the staff can take the technology if that is needed for the patient, or one provider shared an innovative idea with me that they would provide the teledentistry fluoride varnish placement in conjunction with their medical clinic. So while the patient is waiting on the medical side, they would send the teledentistry technology over and either help the medical provider or the legal guardian at that time to place the fluoride varnish. This would help to preserve PPE, as well as if the medical staff is not certified in the placement of the fluoride varnish, that removes that barrier as well because it's under direct supervision of the dentist. Some general concerns and challenges that came up for the policy as a whole was that we required access to both audio and video technology for the services. But what if there's a patient that is having a life-threatening situation and does not have access to this technology? For those situations, at the provider's discretion, we would permit telephonic services. The next question was, what if the provider or the patient is in another state? That is currently under discussion to determine how to address this concern. To keep track of the teledentistry services that are being provided, we are asking the providers to enter the D9995 code. Currently, there's no reimbursement value for this code, and this is just to be able to keep track of the teledentistry services. However, we have concerns of capturing these services accurately if the provider forgets to enter this code. Currently, there's no other way of knowing. So we are considering one of two options, either adding the location of telehealth to our systems. So once the services are provided, that's the location that they would enter the service under. Or if we have system limitations and cannot do that, we are considering reimbursing for the D9995 code for the cost of establishing the technology and the administrative cost, as well as obviously incentivizing the providers to remember to enter this code. Though this policy was initiated to remove barriers during the pandemic, the decision was made to make this a permanent policy, as we realized that it would remove multiple barriers for the patient, potential cost savings to the system due to the reduction of the new disease, lowering future treatments, and the management of existing disease, hopefully lowering the emergency department visits, which of course would lower the cost in that way. Last but not least, it would provide the potential benefit of maintaining our provider network. It would provide a remote alternative for our providers who for different reasons might not be able to provide in-person visits. Either they themselves or their staff or even the patient might have high health risks where an in-person visit is not the best option for them, or in an example where they might be short-staffed for different reasons. It also would help to increase the revenue, especially at a time where the appointments are either further apart or they might not be able to provide all different services. And last but not least, it aids with preservation of PPE, hence aiding with the supply limitations as well as the added PPE cost. This policy in Pennsylvania has not yet been implemented, as we still have a few other questions that we need to have answered, such as the one that was mentioned with the provider or the patient being in a different state than each other. Once these final questions that was mentioned during the presentation are finalized, the policy will be implemented. The rest of the information that was shared has been set and finalized and will be part of the final policy. If you have any questions, feel free to contact me. My email information has been provided on this slide. Thank you.